Professor DOGRA is going to give his first talk on retinopathy prematurity.
Uh, Thank you, Rishi. Thank you for the opportunity. Uh, Sorry, I'm sort of rushing because I have to chair the session in another hall, and the other co-chair is Dr. Lalit Verma. He may not reach there, so I may not be able to start, and most of the speakers are international. These are my disclosures. Retinopathy of prematurity is something, which has emerged as a very important cause of childhood blindness. And the problem is what we observed in our center, that heavier and older infants are developing ROP. And because of that, we questioned the Western guidelines, and that was good. Otherwise, we would have missed a lot of babies. So we have our national guidelines now, which are notified by the ministry, that infants weighing less than 2 kgs in 34 weeks, not what the US guidelines are on other side. And what is very important, given by our own Subhadra, 30 din Roshni ke, that must be examined within 3 to 4 weeks. So it's a sort of a sacrosanct that if we examine around 30 days, we may not miss anybody which requires, any infant which requires treatment. I think the best part is if we can screen and identify treatable stage. So around 90% after treatment, that means a laser or anti-VEGF would show a favorable outcome. So that's a great thing. It's a disease where you can prevent the blindness, provided you have detected that stage. And we are very lucky that this was the first disease to have an international classification, which is still going on with modification till 2021, in which, in fact, our own Anand Vinekar was also one of the participants. So the treatment of ROP requires close monitoring of oxygen saturation levels, which is a problem in our country. We don't have blenders, and we don't have the facilities to do that. 100% oxygen is given. And the peripheral retinal ablation with the laser, which was a gold standard, I would say is still a standard of care with many riders now, and anti-VEGF and vitreous retinal surgery in stage 4 and 5. And the laser is usually delivered in more like less than half burn width apart. That is what, this was a long time back, treated with the diode by me. In 2 weeks time, you can see that plus disease has totally disappeared, and you can see how well the disease get kind of controlled. This was I always say this was the biggest contribution from our center, that once the diode conked up, I started doing with 532 laser, and which was presented somewhere way back in 2006 in American Academy as a poster. They took me on in writing. They said, I'm doing something which is not done. But you see, I'm happy. Today, the same laser which is used for everything is also used for ROP. I think that is what the contribution from our side was. This is one such infant treated both eyes with 532 laser. The laser can also be done through the wall of incubator. I think this, as well as screening can be, this was done much more during the COVID time, and it has a lot of citation that time. People even made contraption based on this, and that is what sometimes even a small thing can prove very, very handy, and this is something which I had done for the first time way back in early years. And anti-VEGFs in ROP, this is a big thing now, are slowly becoming more acceptable, most used for aggressive ROP and ROP in zone 1, but the late recurrences and sometimes systemic adverse events are a concern. And eyes treated with anti-VEGF needs frequent and long-term follow-up. That is a big problem. These babies get bigger. I think we did write one narrative, and which is being cited more and more, along with Anand. And here, I think I put a question mark that once the vessels have reached after anti-VEGF zone 3, whether we should laser or not. I think it depends on how comfortable. Many may not, they'll observe. And ideal is deferred laser till vascularization is proceeding, so that you can preserve more retina and let it go beyond zone 1 into zone 2. That is what we do most of the time. And anti-VEGF injection that way will be followed by less extensive laser, and not like the old time. The problem is sometimes the babies are growing bigger, it's very difficult, and you may need GA. That is what happened. And the current surgical techniques are scleral buckling, lens sparing vitrectomy, and the lensectomy vitrectomy. I think lens sparing vitrectomy is boon. I used to do a lot, and I'm happy that our people now, they are very much into this. You can see one such baby. I think this I did in 2017. It is written there. You can imagine the way it came, the laser. It went into ROP stage like 4B, but just went in. Didn't you see how vascular it is? It just cut what is essential, and the retina will go back, and we could prevent this child from going blind. And lensectomy, vitrectomy for stage 5 is a problem. One third may reattach with a very poor visual outcome. We don't want to let them go there. That is what I think we had done this study that in our country we are getting a lot of stage 5s. Late they come at stage 5. The problem is this study done by us and by Professor Azad and others from RP Center. I think we showed that 80 to 89% were never screened in this series. That is what, and many a time these are the parents who noted that their child is not seeing. So even the pediatrician's referrals were really dismal. We have to change this. This is very important. We don't want to see a baby like this. Nobody can prevent now anything, or this baby will not be able to see whatever, how big the surgeon one may be. So it's very important that how do we prevent the blindness from ROP, reduce incidence through excellent neonatal care, detect timely ROP, as I said, the screening and knowing screening guidelines. And you can, if you can detect them early, that is how you will be able to sort of save these babies. I think we ourselves, I gave the first thesis in 92 to Rohit Charan that time, and subsequently I had given thesis to another girl. This was towards after 20 years, and what we found out, the smaller babies were surviving now later on, even very tiny one, not that time, you see. But the incidence of ROP has come down. That is what is important, that you have to improve that kind of neonatal care with a collaborative effort and dialogues. And Anand also did a similar study where in his case the aggressive ROP came down in the Karnataka area from 20 to 13%. So in conclusion, ROP blindness is preventable in majority of babies, and higher birth weight babies develop ROP in India, and screening is most important to identify treatable ROP. And manage all treatable ROP promptly with laser or anti-VEGF. And the lens sparing vitrectomy to me is the most promising and should be done by most people. It's not a big challenge. It's only the general anesthesia which has to be given and the supportive team or pediatrician or neonatologist. And the vitreous surgery, don't let them go to stage 5. I think then it's almost lost. And the major problem is suboptimal neonatal care and the delayed screening. If we can take care of this, we'll not have. We are landing into a big trouble otherwise because of the blindness due to ROP at this time. Thank you very much.
Thank you, Professor DOGRA, for your excellent presentation, as always. And you have saved our 5 seconds because previous people have wasted our 15 minutes.
Thank you very
any
much.
question?
And sorry, I have to.
Yeah. Please go ahead. Please go ahead.
I
No
have
issue.
to chair session in the other. If there is anything demanding, I can answer that. Otherwise, thank you very much.
Thank you so much.
Thank you, Dr. Rishi, for.